so case one. We have a 32-year-old female with moderate POAG. She's well controlled on her dorzolamide, timolol, and her latanoprost. On today's visit, she tells you that, she's 10 weeks pregnant. So what would you talk to her about, and what kind of treatment changes would you make in a pregnant woman with glaucoma?
Leaving it to the visitor to... this person is on dorzolamide, timolol, and latanoprost, and each of those have possible effects on either the baby in utero or the baby ex utero, or postpartum, I guess is the medical term for that. But I think what I would tell them, I think for those medicines there, I would go over latanoprost as a prostaglandin analog, and it's been theoretically associated with miscarriage, and so there could be a risk about that. And timolol and dorzolamide are safe during pregnancy, but I would ask them to talk to their OBGYN and make sure their OBGYN is okay with them to use those two medicines. On a personal note, my wife had preeclampsia with two of our three children, and the OBGYN had no problem with putting her on high-dose beta blockers. So I'm not sure if we're more nervous about that as ophthalmologists because we just don't use it that commonly, but OBGYN supposedly uses beta blockers all the time for preeclampsia and hypertension.
All of those medicines are in Category C, which means that in animal studies they've been found to cause problems, but there are no adequate human studies that show there's any problems with it. I typically would leave people on timolol. I usually don't use prostaglandins. Timolol's safe, and I always tell them to ask their OBGYN.
Anything to add, Chris?
Yeah, the only other thing is it really depends on the severity and the level of pressure, and I would try to get just kind of empirically off all the medications you can safely because they are Class C. IOP does significantly lower during pregnancy and gets lower as pregnancy advances. So I think that's something to keep in mind. When prostaglandins are used to induce labor, they're squirted directly onto the cervix. So the serum concentration of latanoprost is extremely low, and so I think that's probably a little overstated. And there are several people who would argue that latanoprost is probably safe in pregnancy, but miscarriages are common, and what causes them is unknown. So I think there's certainly a medical legal fear around that. I'd worry more about timolol because of the fetal heart rate effects, but you're right, the obstetricians are very comfortable with it. Alpha-2 agonists need to be stopped around delivery because the effect on newborns is well known. But all in all, I try to get them off everything if it's tolerated. Another approach in somebody who has a higher pressure and has significant damage is SLT because it's a temporary effect, but you don't need a long-term solution, and that might help you get off get off the medications in the short term during pregnancy and allow time for the pregnancy effect on intraocular pressure to come into play.
Great. All right. So she did great during her pregnancy and she had the baby. And so now she comes in and she's 4 months after delivering, but the pressure has spiked way up to 40 in one of her eyes and she's still breastfeeding. Do you have any changes or what kind of medicine?
We use an alpha-agonist.
Okay.
I think the rest of them are okay.
So I kind of went over.
Again, I would ask the pediatrician.
Yes, definitely. So I went over just a little bit. There really is no high-level evidence of the fetal effects from all these glaucoma medications. And like we said, the actual concentrations are probably pretty low in the blood. We just don't really know that well. Some things that I read said that the systemic carbonic anhydrase inhibitors and the prostaglandin analogues, some people said absolutely should be avoided in pregnancy, but again, that could come back around to kind of what's more of a medical legal risk. In some places I read said try to avoid all glaucoma meds in the first trimester, thinking that maybe that would be more teratogenic, but I mean, you'd kind of just have to warn your patients that are of childbearing age ahead of time that to let you know if they're thinking about becoming pregnant, I would say. And then the biggest thing is just with the breastfeeding to avoid the alpha-agonists. I kind of made a little chart here. And again, there's definitely some gray area in here. But the main thing is the beta blocker, I think, is safe in both. And some recommendations were saying not to even use it in breastfeeding because of the worry that it could be secreted in the breast milk. However, now there are major treatments for capillary hemangioma with the systemic timolol. So I think that is kind of out of the water, not important. I think the biggest thing is the alpha-agonist. And I would say, and the oral carbonic anhydrase inhibitors during pregnancy. So, all right. Any other questions about that? Okay.
The only thing else I'll just add is there is a theoretical risk for the carbonic anhydrase inhibitors for decreasing breast milk production. So it's not something that I would typically talk about with my pregnant patients, but if they said they had problems with lactating, that would be something to think about stopping.
Okay, case 2. So you have a 72-year-old African-American male with severe glaucoma with an IOP that's above goal, and he has progression on his visual field. So he had a trab many, many years ago. That scarred down. Then he had a Baerveldt shunt placed in 2007. And now that he's progressing, what are your kind of typical next steps? Do you do another surgery, do laser, put a shunt in? Where do you put the shunt? What kind of shunt would you do?
I typically do a second shunt inferior nasally, and usually it's almost always a Baerveldt 350. I put it inferior nasally because it depends on if the patient has 1 or 2 eyes also. If the patient has 2 eyes and decent vision, then I would always put it inferior nasally. If you put it superior nasally, you can get a pseudo-Brown syndrome. So I typically go inferior nasal with a Baerveldt.
Do you do anything different, Steve? I don't. This is a tough case, obviously, and I wouldn't do another trab on this person if they already. And I don't know. It kind of depends on how long the tube worked. It sounds like it worked for 7 years, maybe, or 9 years.
Yeah, 7, 9.
And this person's 72, and so I guess I could also say that put a different one in, and it might carry them over for their lifetime. There's actually a randomized controlled trial right now through the AGS, which is looking at this exact question, is whether or not you do a diode in this person or whether you put it in a separate shunt. And I can see the benefits for each of those approaches.
So yeah, in patients that fail outflow surgeries more acutely, like the shunt lasts 6 months, a year, I think I'd move forward to a ciliary body ablative procedure. The central acuity also plays into that, and that there's a greater chance of losing central acuity with ciliary body ablative procedures than a shunt. But in general, by and large, I would do an inferior nasal Baerveldt as a second procedure.
I feel like recently we've been doing more transscleral diode procedures and not as much endoscopic ciliary ablative procedures. Have you guys noticed that? I mean, our fellow, he said he hasn't even seen an ECP this year.
Yeah, we did one last week. But the first time, I think, I prefer the ECP over the diode because there's direct visualization. I think the micropulse may change a lot of that, but my surgical volume chair has dropped off significantly, so I'm probably doing. And then maybe one reason they're not seeing a lot of ECP.
The one thing about ECP that's different from transscleral is ECP, as Chris said, you visualize the ciliary body and you can directly ablate it. But transscleral actually will get the blood supply as well. And so there's been a couple studies where they've looked at ECP and you can see the ciliary body grow back over time. And so I also wonder whether transscleral may be a better long-term solution, and you can do it in the office. It's costs less, obviously, but I don't know if anybody's really made that comparison of ECP versus transscleral.
Okay. Case 3. This is a 68-year-old white male with early glaucoma, well-controlled on latanoprost. He complains of glare at night while driving and also has some visually significant cataracts. So you decide to do a CE-IOL, iStent. What kind of things do you all do to prepare? You want to share some of your intraoperative experiences, any trials and tribulations, and then some of the post-operative successes or failures or just kind of pearls that you've picked up from doing it recently.
What's his visual field defect? How severe is his glaucoma?
He has no visual field, just nerve changes.
Just a plain cataract.
It's just very, very mild glaucoma.
Yeah.
But he's on a drop.
Just a plain cataract.
Oh, you wouldn't even do it, you're saying?
I did last year.
So what's changed? Why have you...
I think some of the studies that are coming out don't indicate that it's that beneficial. It's an expensive extra procedure, and a lot of the patients that I do cataract surgery on, especially in the African American population, I will commonly get this post-operative chronic inflammatory reaction that can last for months. I've got some cataract patients African Americans that are on a steroid drop for several years after cataract surgery because I can't get their inflammation controlled, and then I compound that by having put an IStent in. I don't know if it has anything to do with the iStent or just that they are prone to get a chronic uveitis after cataract surgery. So it's too many variables in someone who is well controlled without any significant disease. I typically prefer just to do a plain cataract.
I totally agree too. And if this person was an 88-year-old who needed their cataract out and you just didn't think they were going to be very good with their drops, or they had moderate glaucoma, I would, offer them an iStent as well. But I also have been a little bit underwhelmed that I can't tell who does well with the iStent and who doesn't. And so I think I would, this one I would probably not just do a straight cataract on them and see how they do, and then usually they get off the latanoprost anyway.
So you lean more towards if they're a little older and a touch more severe glaucoma? Yeah,
those that are older have pseudoexfoliation, and those that seem like they just want to have the highest chance of getting off the drops, those are the ones I'll do the iStent on.
Yeah, I think I'm concerned about the long-term data that's emerging on the effectiveness of iStent. There are a couple of new studies now looking at placement of iStents using fluorescein collector channelography to identify where the collector channels are. And one thought is that the variability in shunt placement really depends on where the collector channels are in relation to the iStent, because there's really not there's clearly not circumferential flow in Schlimm's canal. So if it's going to be effective, it's going to be adjacent to a patent and functioning collector channel. So one of the things I think that's possibly helpful in putting in the iStents is decompressing the eye a little bit before cataract surgery and putting the iStent in before the cataract's removed. And I haven't done that except in the last couple of times. And that allows you to get reflux of blood into Schlimm's canal, and you can eventually visualize where the appropriate collector channels are. That does work. You will get some reflux. And once you put the heel on it, it kind of locks the blood in place in the Schlimm's canal. And whether that's effective or not, I don't know. And whether it will be as effective as fluorescein collector channelography, it hasn't really been determined. But if you look back at the history of glaucoma surgery, all these new surgeries have come and gone: deep sclerectomy, viscocanalostomy, and they all come out, and their first papers look like the greatest thing since sliced bread. The pressures are low, visions are good, everybody's happy. And then a few years later, it's combined with cataract surgery, and again, vision's low, pressure's good, everybody's happy, and then it's abandoned. And so every sort of surgical procedure that comes out looks great at first, doesn't work, gets combined with cataract surgery because it exploits that lowering you get from cataract surgery, and then they go away. So, we're seeing this as you get the chronic follow-up of these newer interventions, that they may not be working as well as the initial FDA data. The data used for their FDA approval shows, because we're, of course, dealing with a chronic, lifelong disease.
All right. I have one more. This is a 62-year-old white female with normal tension glaucoma. The IOP has consistently been 10 to 12 on all visits. A diurnal curve was done in the office. It was totally flat, and it's an average corneal thickness. So I have a couple pictures here in the GPA. So did you want to go over this, Chris, or...
Sure. So this is obviously a confirmed inferior arcuate defect, and corresponds to a notch superiorly in the nerve surrounding beta zone atrophy.
So this was 01, and this was 02, And then, yeah, here's the notch. And then when we go forward here, this is 03, this is 03, just about 10 months later. This is the progression analysis here. And this is highlighting the importance of the photos. I've got this big disc hemorrhage right there. That's also then correlating with this increase in the inferior defect. And this one is 04, hard to read, 05, and these are both 2006, January and July.
So what's the time period again? I can see the dates very well. Over what time period did she advance?
Initially, it was 2000. The first two were 2001, 2002. So this has been over about 5, 6 years.
So there's a good example of GPA progression. You have a cluster of 3 points that are reproducible across 3-4 visual fields. So very reliable, stable indicator of progression, preceded by a visual field defect in the corresponding area of the nerve.
So a pretty
definite progression in a patient. So the question is really
62.
Definite progression in a young person with a flat
with such a flat curve and pressures of 10 to 12.
And there's no terminal diseases, are there?
No, with definite progression.
So Steve, what would you do? Say maximum medical therapy, flat diurnal curve, low pressure.
Pressure of 10.
I'm just worried here because I'm just thinking to myself, the latest visual field we saw is 2006. So we still have 10 years to hear what's going to happen.
Let's pretend we're in 2006.
Well, first I would ask this person about adherence, and it could be that this person, she got disc hemorrhage with pressure of 10 as well. I'd ask her about adherence, and I'd offer her surgery if she says that she's pretty adherent, and she, I don't know what her decibel change is over that last several years, but it didn't look like it was a huge change in decibel.
No, this one's mine.
But
they're all about, this is minus 2.27.
So she's got pretty small changes in her visual field over that time. So,
2.34.
She's got a slow change, I think. And although she is progressing, she's progressing slowly. The downs, it does look like it's progressing close to fixation, though. So, I don't know. She's got some reasons to be aggressive. She's young. She's got a visual field defect close to fixation. She's got some reasons to just watch her for a little bit longer, meaning that her visual field loss is slow.
If she is adherent and her diurnal curve is flat and her corneas are thick and her pressure is 10, what's your target?
You're asking me.
Yeah.
Well,
you're going to do a trab, right?
If you do a trab on her, and I think I've done several trabs in these patients, and these patients usually are bilateral. I mean, the ones that I think she's bilateral too, and usually I'll offer a trab to one eye, and sometimes you'll get their pressure about the same level, and everything seems to stabilize, and I don't really know why. Maybe our diurnal tension curve isn't as associated with really what's happening with her pressure, but they do seem to stabilize in that one eye. But I have had a few where they seem to just kind of continue to go downhill, especially some elderly people.
Pardon? Oh, was an MRI done?
No. Color vision was normal, and with a color vision normal, I don't think there's any indication for an MRI. The ability to get a visual field defect of that magnitude and not affect color vision from a compressive process is pretty much not possible. Brian? I think there's that one Japanese study. There's no great evidence for calcium channel blockers other than that, and there are some really significant problems with the way they looked at progression in the Japanese study. So I don't know that there's really good evidence for it. The other issue about compliance, low blood pressure is a big issue. So if they're being treated with hypertensive medications and have low blood pressure, that's something you can intervene with. Whether I would avoid a beta blocker as well, but whether salt tablets and these other approaches that have been suggested are effective, there's just no data. And So I'm probably more conservative in that if their pressures are low teen, there's good evidence if somebody's fluctuating in the mid to upper teens that getting them into a single digit or low teen target retards the rate of progression. There's solid, high-level evidence to support that. There really isn't great evidence to take somebody with a normal corneal thickness from a 10 to 12 range to a 6 to 8 range is going to stop progression, have any effect of the disease. So for me, the benefit is lower than if somebody has a higher pressure. You have more effective treatment, and the risk is the same. And there's certainly significant risk in pushing somebody down with a target of 6 to 8. You can get into hypotony very easily and get into problems there. So I tend to be more conservative. I tell them it's a controversial topic, and that's my opinion, and I offer them a second opinion.
Would you offer her in one eye if she starting to split fixation?
I have not done a trab on someone with a pressure of 10 and a flat diurnal curve and a normal corneal thickness.
What do you do?
I watch them. I tell them to start doing risky behaviors like parachuting out of planes. Don't wear their seatbelt.
All right, well, that's the end of the cases I have. Thank you to all of you.